Hello everyone, today we'll be discussing the acute management of atrial fibrillation with rapid ventricular response. Let's first start with the diagnostic criteria for AFib with RVR. The diagnosis of atrial fibrillation with RVR is based primarily on ECG findings and heart rate assessment. First, atrial fibrillation is identified on a ECG by the absence of distinct P waves, the presence of fine or coarse fibrillatory waves, and an irregular RR interval. The QRS complexes are typically narrow, though they may appear wide if there is a pre-existing bundled branch block or aberrant conduction pattern. Once atrial fibrillation is confirmed, the next step is to determine if there is a rapid ventricular response. This is generally defined as a ventricular rate exceeding 100 to 110 beats per minute, with most contemporary guidelines and studies using a threshold of greater than 110 beats per minute to characterize RVR. So if we were to summarize this slide, the diagnosis of AFib with RVR is made when atrial fibrillation is present on the ECG and the ventricular rate exceeds 100 to 110 beats per minute. The initial and most critical step in managing a patient with atrial fibrillation and RVR is assessing hemodynamic stability. This determines the treatment pathway and helps guide urgency and as well as medication selection. Patients are going to be characterized as stable, peristable, or unstable based on systolic blood pressure and the presence of symptoms such as altered mental status, hypotension, or signs of shock. Stable patients, they have a blood pressure, systolic blood pressure above 90. In these patients, the primary goal is rate control, especially if the heart rate is greater than 130 beats per minute or the patient is symptomatic. Initial therapy often starts with intravenous medications with transition to oral agents once the heart rate is controlled in these patients. Magnesium sulfate is recommended as a first-line adjunct, typically 2 to 4 grams IV empirically, as it may increase the success of both rate and rhythm control. A 2021 JACC study supports the use of IV magnesium in atrial fibrillation management. The main pharmacologic agents for rate control are beta blockers and 9-dihydropyridine calcium channel blockers. Metoprolol is preferred, which is a beta blocker in most cases. It is administered as an IV bolus of 2.5 to 5 milligrams over 2 minutes, repeated every 5 minutes as needed up to a maximum dose of 50 milligrams. Once stable, patients may be transitioned to oral metoprolol up to 400 milligrams daily in divided doses. However, beta blockers should be used with caution in patients with bronchospasm or acute decompensated failure. Diltiazem, a calcium channel blocker, is another effective option. The typical IV dose for this medication is going to be 0.25 milligrams per kg over 2 minutes, repeated every 10 to 15 minutes as needed. Oral diltiazem can be used afterward up to 360 milligrams daily. For this medication, dosage adjustments should be made in hepatic or renal impairment, and diltiazem should be avoided in patients with left ventricular ejection fraction less than 40% or those in acute decompensated heart failure. Once rate control is achieved, it is going to be essential to investigate and manage any underlying causes of AFib, such as infection, volume overload, pulmonary embolism, alcohol intoxication, MI, or pericarditis, and so on. Peristable patients have a systolic blood pressure between 80 to 90. These patients require a more cautious approach due to their borderline blood pressure. In these cases, low doses of beta blockers or calcium channel blockers may be trialed carefully. We can also administer IV fluids. These may help if there's no concern for pulmonary edema. When blood pressure is borderline and standard nodal agents are risky, blood pressure sparing agents should be considered. We have two options, including amiodarone and digoxin. Amiodarone can be administered as 150 milligrams IV over 10 minutes with the option to repeat once if needed. If this is effective, it can be followed by a continuous infusion at 1 milligram per minute. This agent offers both rate and rhythm control and is going to be particularly useful when nodal agents are contraindicated or they're ineffective. Digoxin can be a useful alternative for rate control in patients with low blood pressure or concurrent heart failure, particularly when other agents are contraindicated. The standard loading regimen for digoxin is going to consist of 0.5 milligram IV initially, followed by 0.25 milligram IV every 6 hours for 2 additional doses for a total of 1 milligram. For digoxin, it is important to monitor the serum levels of the drug, and this is especially important in patients with renal impairments, and the reason for this is because digoxin is going to be renally cleared. However, it is important to note that digoxin is contraindicated in patients with an accessory pathway that is capable of anterograde conduction, and we have this in patients with Wolff-Parkinson-White syndrome or any pre-excitation syndrome visible on a resting ECG is going to be a contraindication. The reason for this is because digoxin is going to shorten the refractory period of the accessory pathway, and this can potentially allow rapid conduction of atrial impulses to the ventricles during atrial fibrillation. This can result in a life-threatening ventricular arrhythmias. So for this reason, major cardiology societies recommend avoiding digoxin in any patient with evidence of pre-excitation on ECG. Unstable patients are going to have a systolic blood pressure less than 80. In these patients, characterized by a heart rate typically greater than 150 beats per minute, hypotension, signs of shock like altered mental status, cold extremities, refractory pulmonary edema, or angina. So in these patients, immediate synchronized cardioversion is going to be the first-line treatment. The recommended starting energy is 150 joules using a biphasic defibrillator. In unstable patients, pharmacologic therapies are not going to be appropriate due to the urgency of the situation, so we need a defibrillator. If pressor support is needed in unstable atrial fibrillation, phenylephrine is going to be preferred. And the reason for this is because phenylephrine is going to have a minimal effect on heart rate, and it's going to have a lower risk of causing reflex bradycardia compared to agents like norepinephrine. Let's compare the mechanism of action between phenylephrine and norepinephrine to kind of reason through the understanding of why phenylephrine is going to be the recommended pressor in this scenario in unstable patients with atrial fibrillation who need pressor support. So phenylephrine is going to be a pure alpha-1 adrenergic agonist. This is going to cause a peripheral vasoconstriction, and it is going to increase systemic vascular resistance, which is going to raise blood pressure without directly stimulating the heart. Contrast this to norepinephrine, which acts on alpha-1 and beta-1 receptors, leading to vasoconstriction, but also increased heart rate and contractility. And this can result in undesirable tachyarrhythmic states. So phenylephrine selective action is going to allow it to support blood pressure without exacerbating tachycardia or inducing bradyarrhythmias, making it a safer option in this setting. It is important to recognize that higher heart rates, about 140 beats per minute, may cause hypotension due to decreased filling time of the heart, whereas lower heart rates in hypotensive patients often reflect impaired systolic or diastolic function or reduced preload. This is sometimes referred to as the loss of the atrial kick. So the stepwise approach that we discussed, classifying patients into stable, peristable, and unstable, is going to provide a clear framework for managing AFib with RVR in acute settings. And remember, as always, once stabilization is achieved, addressing the underlying etiology is going to be essential to prevent recurrence and guide long-term therapy. Thank you for watching. I hope this video was helpful.